Hello, good evening. Can you hear my voice clear?
Yes.
Okay, so I apologize for the delay that happened today. Let's start immediately. And I'm going to share you my screen. Here we start. So today's session will be about some miscellaneous topics of the optics, like the refraction, like the laser and refractive surgery, intraocular lenses. I guess that you saw the lectures present in the curriculum, and we were going to present the past papers, the questions that appeared in these topics. So today's lecture will not be much easy. It needs a lot of thinking, so I try to explain of the question as much as I can. So let's start with the first question regarding the laser. So what do you think is the most likely laser that has an ionizing effect? This has been mentioned in the lecture. So any other answer? Any other one wanted to share his answer regarding this question? So as Dr. Sadia said, it is the YAG laser. This is the correct answer. So we said before that we have different types of laser. Some of the are can be classified according to their wavelengths or to their mechanism of action. So regarding the mechanism of action, we have some lasers work by the photochemical reaction. Some lasers work by thermal effect, and the others work by the ionizing effect. So the ionizing effect meaning that the laser itself acts by stripping of electrons from their nuclei, causing what's called the plasma cloud. Plasma cloud is formed by the ionization or formed by the electrons, which are stripped from their location by the effect of laser, which will cause the cutting effect or the photo disruption as in YAG laser. So refer to this slide, it's present in the laser lecture. So YAG laser acts is by ionizing effect. Yes, you are. Your answers are right. So regarding the Jacksonian cross cylinder, which one of the following is most likely to be true? A cross cylinder with a positive cylinder power of or positive power of plus 0.25 diopters should be used for a patient who has a good visual acuity like 6/9 or better, because this cross cylinder will show minimum variations between the different positions. If a patient has a gross visual acuity defect or he has impaired visual acuity, he will not be able to appreciate the difference between the very slightly different positions. So this position or this power should be adopted for patients who have very good visual acuity. It is a combination of positive and a negative cylinder, which are 45 degrees apart. So this will be the correct answer. It is not 180 degrees; it's only 45 degrees, and the handle of the cross cylinder is aligned with in the middle or in midway between the plus and the minus. So again, the handle of the cross cylinder is just midway. This is how the cross cylinder works by present as it is present midway between the plus and the minus cylinder. We can twirl or we can flip the Jacksonian cross cylinder so we can rapidly exchange positions between the plus and the minus cylinder. The positive cylinder is the same power of the negative cylinder. So whether it is plus 0.25 and minus 25 or plus 0.5 and minus 0.5, this will be both the same power. So as we mentioned in the Jacksonian cross cylinder, the principle of it is that spherocylindrical length. This spherocylindrical length has a spherical equivalent of 0. So we know that the spherical equivalent is the sphere plus half the cylinder. So how could a spherocylindrical length have a spherical equivalent of 0? This is by having the cylindrical power twice of the power of the sphere and of opposite sign. If we combine spherocylindrical length that has a cylindrical length of twice the power and opposite the sign, the spherical equivalent will be 0. So this means that in either position of the cross cylinder, the spherical equivalent mean be 0. This means that the circle of least confusion will be on the retina. Again, this is the important principle of the cross cylinder, that the circle of confusion is on the retina. So what is the effect of the cross cylinder? It just enlarge it or making it more small, either enlarge or small. And if it is more smaller, so the image will be more clear for the patient, so the patient will choose it or choose the position that makes the circle of least confusion more small, and then we know that we are approximating to his accurate refraction. So if we, for example, if we combined a plus 0.5 diopter sphere with a minus 1 diopter cylinder, this will result in 0.5 diopter cylinder in one axis and the minus 0.5 diopter cylinder in the other axis. So this is the spherocylindrical length that will cause spherical equivalent of 0. The minus cylinder and the plus cylinder are mounted on in the cross cylinder with a handle in between or midway between both of them, and we choose the cross cylinder according to the vision. So if we have a vision of 6/9 or better, we use the 0.25 cylinder. If the vision is 612, then we use the Jacksonian cross cylinder, which is having 0.5 diopter cylinder. Is it clear?
Yes.
By the way, Dr. Nihal, did you understand the explanation that I gave for your question regarding the cross cylinder?
I don't see it now. Inshallah, after class, I will see your answer.
Dr. Nihal, you already sent a question in the website and I already answered it. Did you review my answer? Okay, I guess that you are the... Okay, no problem. Okay, let's move to the next question. Okay. Okay, so regarding the near correction, which one of the following three statements are true? We don't give the strongest lens that the patient can tolerate. Actually, when we are giving the patient the near correction, he will, as you increase the power, he will be happy because the image of the near target will be more clear and more large. We said that before in the aphakia. This is one of the drawbacks of the aphakia, that when you are correcting the patient with a plus lens, he see the image, or he has better performance in the visual acuity because he actually sees the letters are more large. This is what happens during the near correction with a plus lens. So if you are giving the patient plus lenses, he will report that the letters are large and he will be happy. So are you happy as well? The answer is no, because actually if we increase the plus lens over plus 3 diopter, this will eliminate the patient own accommodation. And if you totally eliminate the patient own accommodation, this will result in that the patient will not converge. We know that the near reflex consists of both convergence, meiosis, and accommodation. So accommodation is important as a stimulus for convergence. If the patient doesn't accommodate, he will not converge. And what happens if the patient doesn't converge? Actually, he will complain of athenopia. So when you are present a near target in front of him, he should converge in order to place his both eyes over the near target. But if he doesn't converge because he doesn't accommodate, then he will be complaining of some headache and eye strain. So this is not a true answer. We should start our near accommodation by establishing first the full distant correction. So we should correct the distant spherical correction like the myopia or hypermetropia together with correction of any astigmatism that's present in order to mount the plus correction or the near correction over it. This is the true answer. Although that in practice we test both eyes together, but actually in optically speaking we cannot or we every eye can have different accommodation from the other eye. Like for example, in a patient who has pseudophakia, so a patient with the pseudophakia, he has total lost accommodation in one eye and he has some reserve accommodation of the other eye, so it will be wise to test each eye separately. This is, I think that is an easy question. Yes, that's correct. As we mentioned, that the patient with a unilateral pseudophakia will have to be fully corrected for near in one eye, while in the other eye should be left some reserve accommodation for the patient in the other eye. For the other options, they doesn't require any different near addition. Are you sure? So this is this is like the this is like the plus lens, and here is the reading segment, which is a base up. So what happens when you add another uh, exactly. It is the raise the height of the optical center in the reading segment. So increasing the reading segment in the lens power, or increasing reading segment lens power, will just increase or add more to the problematic image jump which appears in the bifocal lenses when the patient toggle his vision between the near segment and the distant segment. This will be the most problematic issue for patients using the bifocal lenses. Put a prism base down prism in the distant segment will add more to the problem. So this will cause that the patient will have more prismatic jump, but he will need to add a prism base up in order to neutralize the already base down prism present in the reading segment. Base in, we don't put a base in prism in the distance, and raise the height of the optical center of the reading segment will be one of the solutions to reduce the prismatic jump. So we said before that how to prevent the prismatic jump, we just put a prism base up. So here is the mounted near segment, which is base down. If we put a prism base up, then this will neutralize each other, causing prevention of the prismatic jump. Or we can bring the optical center of the near portion near that the dividing line, or the bringing the optical center of the near segment near that of the distant segment. So we can just approximate the near visual point to the dividing line, or we can approximate the near visual point toward the distant vision point. These are the methods that we use to prevent the prismatic jump. Exactly, your answers are correct. So all those who are practicing will know that astigmatism is not well tolerated by patients. So if the patient is wearing glasses for the first time and you are giving him the full correction of astigmatism, he most likely will refuse the glasses, especially if the astigmatic error will be large or if there is any slightest deviation from the correct axis. So it is wise to consider under correction of the astigmatism initially in order to aid tolerance of the new glasses for the patients. And this is the will be the correct answer. Cycloplasia is usually, or it is in most occasions, is required for refraction of children in order to know how much amount of accommodation that the patient exert. Hypermetropia need to be corrected if there is esotropia or esodeviation. This is correct, but this is not the only condition. As patients also complaining of headache should be also corrected for hypermetropia. Initial overcorrection of myopia may result in control of the intermittent esodiviation. Well, what happens if the patient is having esodiviation, in which his eyes are turned inside, and you increase his myopic correction? So you increase the minus lens in front of his eyes. He will exert more accommodation to overcome this minus lens. So this will result in more esodiviation. So again, this will be not or will be wrong management. Well, a chance of amblyopia through though also under correction is done. Let's differentiate between the question and the real life. In the question, it is not asking about amblyopia, so we don't will go through the amblyopia. But in the real life, usually patients can develop amblyopia if there is a difference between about minus 1.5 diopter of slender between both eyes. So this will be the cutoff value. If you are having some slightest, if you have undercorrected the patient, but you are still keeping the cylindrical difference between both eyes less than minus 1.5, or to be more safe, to less than minus 1, you will not have any, you will not have amblyopia. And by meaning under correction, we don't mean that if the patient has -7, then we go for glasses of -3. Actually, if the patient has -7 slender, he will not be comfortable with glasses at all. So another surgical options like or other options that can be offered to manage this high slender, like rigid gasterium contact lens, like some procedures, astigmatic keratotomy, for example, by femtosecond laser or others. Here is the room is more for surgical options. So we are not talking about high slender to be managed by glasses, but we are talking about like minimal cases of slender or slender below 3 or 4 diopters. Of course, I'm talking about when I mentioned RGP, I'm talking about more the irregular astigmatism rather than the regular astigmatism. So this depends mainly on the case or the cause of astigmatism. Okay, let's move to the next question. So regarding the biometry, which one of the following is most likely to be true? If an eye requires 21 diopter, if the IOL is placed in the in the bag, and this will cause the patient to be immetrope. And for some incident like rupture posterior capsule or vitreous loss or total loss of the capsule, the patient or the surgeon decided to place this intraocular lens in the anterior chamber. How much or what will be the difference in the IOL power? It will be increasing or decreasing, it will be the same. So we are here talking optically. We are going further away from the nodal point. It will be decreasing, yes, that's right. But it is actually, it is, I disagree that it will be 1.5. It will be like about 3 diopters. So it will be for example, if it is 21 and we are placing it in the anterior chamber, it should be like around 18 diopter, but this is will be according to the A constant. So this will depend mainly on the A constant of the intraocular lens, but just to know the rule, because the figures they cannot be always the same. If we have here this is an eye. So this is here will be the intraocular lens in the back. What happens if we try to, or we decided to place it in the sulcus or in the ciliary sulcus like here? This will causing the lens to be shifted more forward, and this will lead to the power to be decreasing, or we should decrease the power like about 0.5 or 1 diopter to reach emmetropia. If we tried or we thought or we decided to further move it more forward to place it in the anterior chamber, like here, again, the power should decrease like about 3 diopters or 2 to 3 diopters in order to reach the emmetropia. So this will be a wrong answer. If only one eye requires cataract surgery, it is advisable to do biometry for both eyes. So this can be detect any similarities in the axial length or in the keratometric reading, especially if the readings are suspicious, like very high or very low axial length or keratometric reading. Then it is advisable to compare between both eyes. If the two eyes have identical keratometry, but the difference in only in the axial length, like 0.3 millimeter, then the difference in the intraocular power will be around 1 diopter. This will be the true answer. We said that we have two major factors that will control the intraocular lens power. This will be the K reading or the keratometric reading and the axial length. And we mentioned that the axial length is much more important than the keratometric reading. And we will tell you why now. The required power needs the axial length as well. So although anterior chamber can be used in some calculations, but a keratometric reading is one of the crucial elements that are incorporated into the IOL formulas. So we can't deny it or we can't ignore it. So we mentioned according to the SRK formula that the power of the lens will equal A constant minus 2.5 of the axial length in millimeter minus 0.9 keratometric reading. So what happens if the patient has keratometric reading 44 and we miscalculate it like 43? This will result in only 0.2 or 0.9 diopter of difference in the power. So this can cause a refractive surprise of more or minus 0.1 diopter. Sorry, 1 diopter. But what happens if we miscalculate the axial length? So instead of saying that the patient has 23 millimeters, we said that the patient has 22. So here is the 1 millimeter difference will be multiplied by 2.5. And this will result in that the refractive or the IOL power will be increasing or decreasing by about 2.5 diopter. So this is for 1 millimeter change in the axial length. So what happens if we only change the axial length by 0.3 millimeter as the question? So it will be 1/3 of this formula. So it will be 1/3 like here. Let's assume that it is 3 diopter. So 1/3 of 3 diopter will be 1 diopter. So every 0.3 millimeter change in the axial length will result in 1 diopter difference in the IOL power, as well as every 1 millimeter of the axial length will result in 3 diopter or 2.5 to 3 diopter of a change in the IOL power. So here again, read the question. If there is 0.3 millimeter difference in the required IOL power for the emmetropia, then it is approximately the IOL will be, difference will be 1 diopter. Okay, let me explain this question because it's rather difficult. So regarding the laser, and actually it is actually talking about the activated laser. This is important because we will need this in the last sentence. A partially transparent mirror at one end of the tube will produce a Q-switched laser. So in we have two modes of laser, one be of the Q-switched and the other will be the continuous. When we are producing the Q-switched laser, there will be the tube and the two mirrors, and there will be a shutter. Here is a shutter. When they are this shutter will when releasing this shutter, this will result in production of shots of laser. This what happens in the Q switch. This shutter is placed in front of one mirror, allow passages of shots of laser. This will maximize the energy and prevent the loss of laser. But this is not what happens. But this partially transparent mirror is not the thing that will allow the passage of laser in the Q switch. So because a partially transparent mirror at one end, if this is a partially transparent, this what happens in the continuous mode laser, like for example, like the argon laser. Again, a partially transparent mirror is used for continuous laser, while a shutter is used for the Q-switched laser in order to allow the passage of laser. So this is not the true answer. Laser may produce light of more than wavelength. That's correct, because we know that the laser can produce, for example, can be infrared rays like that of the femtosecond laser. It can be an ultraviolet rays like that of the excimer laser. So the laser itself can produce lights of different or multiple wavelengths. So you see here, it is lasers. It is S. So lasers can be of many wavelengths. The length of the tube is directly proportionate to the wavelength of the light emitted, meaning that when you are, for example, if we are producing a light of infrared rays like that of the femtosecond laser, like it's about, as I remember, it is like 150 nanometer or 1050 nanometer. It is has a longer wavelength. So this tube should be the multiples of 1050, like 2100 or 3150. This should be the multiplies or multiplications of the wavelength of the laser which should be emitted from this tube. This is a basic rule in the laser in order for what's called resonance to occur. There are always more outer shell electrons in unexcited rather than the excited. Well, this can occur in the resting phase, but in activated laser, the excited should be more than the unexcited form. Again, this is what's called the population inversion. Population inversions mean that there are more excited electrons than the excited, more excited than the unexcited. So to get back or to recap what we have said, what we mentioned in the laser, we said that this laser, or in order for a laser to be produced, we have an active element or active medium. This can be this is what gives the name of the laser, like gas, like krypton, or argon, or krypton, or YAG laser. This is named by the active medium, and there is some energy input. This is light that will hit this active medium. This will result in activation or what's called the population inversions, meaning that the pumping or production or allowing this energy to hit this active medium, this is called the pumping, and it will result in population inversions, in which the more electrons, or the majority of the electrons are becoming in higher energy state than the ground state. So the electrons becomes more excited, and now they are traveling back and forth and back from between the two mirrors, which is called the resonance, in order to make the laser more coherent and more augmented. And then we allow the passage of the laser through one end. If this is through the transparent mirror or partial transparent mirror, this is a continuous mode. If this can be done through a shutter, this is the Q switched mode. Is it clear? Okay, I guess that there are no answers. Let's move to the next question. So here we have some topics that are explained in the physiology. Actually, they are physiology option topics, but they sometimes present them in the optics exams. So we will discuss them in more details in the physiology. So just I will, since they appeared in the optics exam, I prefer to put them here instead of putting them in the physiology revision. So let me explain it immediately. Regarding the visual acuity, which one of the following, again, I stress that the visual acuity will be explained in the physiology. Which one of the following statements is most likely to be true? At the specified distance of the letters of Snellen distance type, it subtend a visual acuity of 15 minutes of arc. This is not true. It only, the Snellen optotypes will subtend an angle of only 5 minutes of arc at the nodal point, which is called the visual angle. Retinal image size will depend on the visual angle. This is correct, as we also will mention later on, that if you have an object in which you subtend an angle of large angle at the visual angle, it will cause much more stimulation of the photoreceptors, causing more size of retinal image, regardless of the size of the object itself. We will see example now. The resolving power of the eye is the smallest letter of the chart that can be identified. This is not true. Actually, the resolving power is a power of discrimination. how to separate two targets. So if we have a target like here and target like here, as long as you are able to separate the two lines, then this is called the resolving power of the eye, or the minimum separable, or the resolution of the eye. The visual angle is the angle subtended by the extremities of the object at the center of the fovea. No, it will be at the nodal point, not the center of the fovea. So these slides are present in the physiology lecture, but we will just see them now. The visual angle is the angle subtended at the nodal point, not at the fovea. So here is that's what's called the visual angle, which is seen by the extremities of the object at the nodal point. We can see the 2 points as separate 2 points if they subtend an angle. This angle is only 1 minute of arc, but actually this is what we if we have 1 minute of arc of separation between the two objects, this will result in a stimulation of one cone and non-stimulation of one cone and stimulation of the other cone. So between every two cones, there will be a single cone unstimulated in between. And this is the basis of visual acuity or discrimination of between the target. For in order for this to occur, this angle should be only what's called 1 minute of arc. But for the optotype, this is called an optotype, and the whole optotype will subtend an angle of 5 minutes of arc because it contains 5 limbs. Every limb of them, in order to be separate, so this will stimulate one cone, and this white space will not stimulate the cone. This will stimulate the cone, and this will not stimulate, and this will stimulate. This will result in identifying where is the opening of this E letter. And in order for this to occur, the letter itself is have an angle subtended at the nodal point of 5 minutes of arc. The resolving power is the ability of the eye to separate objects based on the visual angle, not to see the smallest object, but it is the ability to separate the objects. And the resolving power, as we increase the size of the image at the nodal point here, it will cause much stimulation of the photoreceptors on the retina. Like, for example, if you are holding a coin in front of your eyes and put it in front of the moon, although the moon is much larger than the coin, but you can see that the coin will obscure the moon appearance or the moon picture, because the coin is subtending an angle at the visual point which is much larger than the image which is subtended by the moon, resulting in that the retinal image size of the coin will be much larger than of the moon. But I guess that you already have a hint about this from the magnification lecture in the optics. So I guess this is not totally new. But it is just how to process the information that you listened to in the classes. This is what is the value of the MCQ, how to know where is the information and how to process it. Okay, let's move to a next question that was should be discussed in the previous lecture about the accommodation and the convergence ratio, but I just forgot to put it, so I'm presenting it right now. Okay, let me explain this question for you. We all know that in order to see a near target, there is a triad that will occur. This is called the near triad. In the near triad, there is accommodation, there is convergence, there is meiosis. So in order to see a near target, and we have both eyes like this, the eye should converge, and the lens should accommodate, and the pupil should undergo meiosis. So since these events occur together, meiosis doesn't have any grading, but the convergence and accommodation, there should be a ratio that will control both of them so that a patient or an individual can converge for a certain amount of prism diopter in relation to an accommodation of certain diopters. What is this relation? This is called accommodative convergence to accommodation ratio. This ratio is like 1 to 5 or 1 to 3 to 1 to 5. This is normally. What is meant by 1 to 3 to 1 to 5? This is mean for each one diopter of accommodation, a normal individual will undergo convergence of 3 prism diopter to 5 prism diopter. This is the normal accommodative convergence to accommodation ratio. So how can this be measured? This can be measured by two methods. One is called the gradient method, and the other is called the heterophoria method. And we will talk about them now. It is low in children with exodeviation. This is not true. This is not true. Don't want to go much into strabismus details. It is lowered by cycloplegics. Actually, again, this is not true. This is simple to explain because if we are giving cycloplegics, this will result in that the accommodation here will be lost and the accommodation here will be lost. So since that accommodation here and there will be lost, so the ratio will be the same. This is only convergence. It is helped by orthoptic treatment when high. Actually, this is again not true. If the patient has high accommodative convergence to accommodation ratio, this is the orthoptic treatment will fix only the convergence, but it will not fix the high convergence in relation to accommodation. So this can be fixed by the bifocal lenses. For patients who have high accommodative convergence to accommodation ratio, this can be treated by bifocal lenses. Those patients will have heterophoria for far and have esotropia for near. So regarding the accommodative convergence to accommodation ratio, as we mentioned, this is like 1.3 or 1 to 3 to 1 to 5. This can be measured by two methods. One is called the heterophoria method, and the other is called the gradient method. The heterophoria method can be calculated by adding the intrapupillary distance to the difference between ocular deviation for far minus ocular deviation for near divided by the near fixation distance in the diopter or the dioptric power of fixation. Let's say, for example, that the patient maximum accommodation is like 4 diopters as he fixes in 25 centimeters, or we have this test in 25 centimeters, so the D will be equal to 4. Another method for measuring the accommodative convergence to accommodation ratio is called the gradient method, in which we are again we taking the difference between the ocular deviation for far minus the ocular deviation per near per D or divided by D. But actually here D is not the power or not the near fixation distance in the diopter, but it is the power of minus lens. So what is the minus lens? This is the minus lens which is used to overcome the accommodation. So we know that when the patient is exerting accommodation, we are putting minus lens in front of his eyes in order that he can overcome it and we can calculate the amount of accommodation that he has. Honestly speaking, both of these methods are not used in the real life or in practice. Much more simple methods are used to calculate the accommodation convergence to accommodation ratio. And you don't need to know all these details in the context of the optics exam. You just need to know that both heterophoria method and the gradient method are used for calculating the accommodative convergence to accommodation ratio. So just wanted to add this information from the previous lecture. If anyone have a difficulty to read the question, please let me know to read it for you. So let me explain more the option D. With large cylinder, the cross cylinder can only determine the axis within 10 degrees accuracy. So let's say, for example, that patient has minus 5 cylinder and another patient has minus 20 diopter of cylinder. This will result in that the patient, or according to the question, those who have minus 20 diopter cylinder can be determined within 10 degrees and that of the minus 5 will not. So does the power or the power of the cylinder has any relation to do with what is the range of detection of the accuracy of the axis of this cylinder? Let me tell you something that actually we measure the axis before the power. So, or we detect the accuracy of the axis with the power. So what will be the value of the power at all? It will be of no value at all. Okay, I'm glad that you are saying that other options are wrong. So let's explain and see how the other options is not true. Regarding the cross cylinder, which one of the following is most likely to be true? The cross cylinder is useful in verifying that no cylinder is required in the spectacle lens. Actually, this is the true answer. And actually, this is actually my mistake that I put the slides of or when I discuss the cross cylinder in like clinical courses, I used to put this slide in the front or in the beginning of the cross cylinder topic because this is actually a step in the clinical refraction of a patient when we are trying to do him cross cylinder. The first step is to examine or to check in the start if he has cylinder or not. And this can be done by the cross cylinder, as I will tell you now. But when I made the basic or the optics course, I thought that this slide will not be important because this is not a clinical test, but it turned out that they are asking about some clinical information, so or some practical information. So I put the slide here in this presentation again, and I will tell you how to do this or how to discover if the patient has cylinder or not using the cross cylinder. So anyway, this is the true answer. The line marked plus 0.25 indicates that this is the axis of no power of the minus cylinder. Again, this is not true. We said that the cylindrical power is actually 90 degrees over the perpendicular meridian, or the power is 90 degrees over or in the perpendicular meridian. So this is not true. The spherical equivalent of the cross cylinder, it is 0. Again, this is not true. With large cylinder, the cross cylinder can only determine the axis within 10 degrees of the accuracy. We said that this is not true. It has no the accuracy of the axis has no relation to the power of the cross cylinder. So let me tell you how to adjust or how to detect if there is a cylindrical correction or not. Actually, this is, as I told you, this is from my clinical course. So in order to, after we do retinoscopy of the patient and detect the spherical power, we need to know if the patient has a cylindrical power or not. So if no, if the patient has no cylindrical power, we have to discover the cylinder. But if if the patient after retinoscopy, it showed that the patient has cylindrical component, then we need to refine the axis first, then the power. So we discussed this arm, how to refine the axis and how to refine the power. But how to detect if the patient has cylinder or not? This can be done by the following procedure. We place the Jacksonian cross cylinder at 90 degrees and 180 degrees to check for the astigmatism. So now we don't have astigmatism. With the patient has, for example, -3 diopter of a sphere. So we place the Jacksonian cross cylinder with the handle like 90 degrees, and then the handle like 180 degrees. So this what will happen. This will cause screening of the 0 meridian and 180 and the 90 diopter, or sorry, 90 degrees. This will result in screening of all these axes. If the patient has any preference, if the patient has no preference at all, then we can proceed to the next step. But what happens if the patient has a preference? Let's say, for example, when you put the Jacksonian cross cylinder at the 90 degrees and 180 degrees, there is no preference, or let me say that if the patient first has no preference, then we can check at the 45 degrees and 135 degrees. So that if the patient again has no preference, then the patient has no cylinder. But if he has any cylinder, then we can add the cylindrical power. Just hold on. So if the patient has or prefer a certain position, then we add a cylinder with the axis parallel to the respective plus or minus cylinder. And then we start the discovery of the axis as the normal procedure. So let me explain this to you. I don't know if there is a white screen or not. Okay, let's just hold on. I will make a white screen and I will explain more in this white screen. Okay, let's explain on this. No need for the white screen. So let's assume that the patient now having having a spherical eye or spherical correction like -2, and there is no cylinder at all. What will you do? So here his eye. What you do is that you are placing the minus and the plus in 180 degrees and the 90. So what happens now? You are now placing the plus 0.5 over the 90 and the minus 180, and then you flip the cylinder. When you flip the cylinder, you reverse. So you will place the plus 0.5 at 180 and you plus 0, minus 0.5 at the 90. If the patient reports that there is no preference, so there is no cylinder at these axes, but the patient can have cylinder in the 100 and in the 45 and 135. So what can you do? You again place the plus and the minus cylinders at the 135 axis and the 45 axis, and you start flipping. If the patient again reports that there is no preference, then the patient has no cylinder. So the cross cylinder can be used to identify or to confirm that the patient has no cylinder. But what happens if the patient prefer a certain position? Let's say, for example, that the patient prefer this position where the plus is over the 90 or the minus over the 80. So now you are wanted to, so you can either work on the plus cylinder or work on the minus cylinder. If you are trying to work on the minus cylinder, then again, for any position, place the handle over the axis and start to flip in order to discover the axis. And after discovery of the axis, you can start discovery of the power. So you just need a starting point. What is the starting point? It is the position of the cross cylinder at which the patient prefer his vision with. If the patient has any preference, then the patient has cylinder. This is the bottom line of this whole story. So, Dr. Siddharth, did you get it as you was telling that all options are wrong? Okay. Okay, let me explain this question for you. Regarding the refraction test, which one of the following statements is most likely to be true? A pinhole improves the ametropia by diminishing the size of the blur circle at the retina. This will be the correct answer because the principle of the pinhole is that it will eliminate the peripheral light rays. So if the patient has myopia or hypermetropia, this will cause refraction, irregular refraction, or not saying irregular, but it will cause refraction by the peripheral part of the cornea and the lens, and this will cause different blurring or blurring of the image over the retina. And what happens is that the pinhole will allow only the central light rays to hit the retina. So it will eliminate the effect of the peripheral light rays, which will cause blurring or blurring images or blurring circle over the retina. So this is a true answer. A stenopic slit act as an elongated pinhole. So this can be used for astigmatic patients. And when we are putting the cylinder or we are putting the slit at the in one principal axis of the astigmatic eye, then the second axis or the second line focus is eliminated. So in order to have an improvement of the vision, we need to put the slit at the axis of the cylindrical required. Again, like here, if we have a slit, if the patient has an axis of 90 degrees, this is the axis of the patient. In order to have a clear image, we need to put the slit within the axis of the patient because this will eliminate the perpendicular image. The perpendicular image which is at 180, it will be blocked by this stenopic slit, allowing the patient to see clear image. Because again, he is now not suffering from astigmatism, as it is allowing only the light rays within the 900-degree axis to enter through the retina. This is the principle of the stenopic slit. When measuring the interpupillary distance, measurement should be only taken from the center of each pupil. This can be correct. The IPD can measure by taking measurement from the center of each pupil, but this is not the only way, as I will show you now. When measuring the interpupillary distance, the subject fixate on the distant target, because if he fixate on a near target or fixate between the two eyes of the observer, he will be accommodating and he will be converging. So when he converges, this will result into shortening of the interpupillary distance, which will not give an accurate measurement of the IPD. So here we have this is the principle of the pinhole. The pinhole act as a small central aperture that will allow only the central light rays to hit the retina. This will result in clear image, but because if the patient has myopia or hypermetropia, this will result in blur circles. Every light rays that will be refracted by the cornea or the lens will produce an image causing blurring of the image over the retina. Here, this is the stenopic slit, and the stenopic slit is used to determine the principal axis of astigmatism, as it acts as elongated pinhole, allowing the light in the axis of the slit only to enter the eye. So let's say, for example, that the patient, when the slit lies in one principal axis of the astigmatic eye, the second line focus is eliminated. So here, if the patient has 90 degrees and here is the horizontal line is eliminated. So when the horizontal line is eliminated, a clear image will produce. Again, we put the stenopic slit within the axis of the cylinder in order to eliminate the perpendicular image that is produced. It will be blocked by this blackish area. So result in more clear image. And when we are measuring the interpupillary distance, they are measured by this from the center of the pupil. But another way to measure the interpupillary distance is to measure it from the nasal limbus of one eye to the temporal limbus of the other eye, or here from nasal limbus of one eye to the temporal limbus of the other eye. So it can be used in both ways. Okay, so this question and a lot of similar questions will depend on a principle, which is some refractive principles of the corneal surgery, which is the astigmatism that result during suturing or during incision. So when we are incising or we are doing incision in the cornea, this incision will result in scarring, and this scarring will cause flattening of the meridian that is affected by this incision. On the other hand, suturing of the cornea will result in steepening of the meridian that is affected by this suture. So if we want to flatten a meridian, then we can go for incision. Like, for example, the limbal relaxing incisions and the astigmatic keratotomy incisions that can be done manually or done by the laser. If we want to steep a meridian, then we can go for compression sutures, or we suture this meridian in order to make it more steep. This is the simple rule that you can apply for any question regarding this. So here we have a patient who has cataract or complicated cataract surgery that he underwent extracapsular cataract extraction. Then we did a superior wound. This superior wound is closed by 5 interrupted sutures. This will result in cylindrical correction or cylindrical power after the surgery, post-operative cylinder of -3 at X of 150. So we need now to correct this 150 or -3 cylinder at 150 degrees. So which single suture will cause the much reduction of astigmatism? We have suture at 1 o'clock and 2 o'clock and 10 o'clock and 11 o'clock. To understand this, yes, it is, as your answer is right, it is 2 o'clock. So I just made this illustration. Let's say, for example, that there are 5 sutures like 10 and 11 and 1 and 2 o'clock and 1 o'clock and 2 o'clock. And then you correct this patient by -3 cylinder at axis 150. This means that you are by putting minus cylinder over axis of 150. This means where is the steep meridian? The steep meridian will be at 60. 60. Because the minus cylinder actually acts by weakening of the perpendicular meridian. So if the 60 degrees is the steep meridian, and by 3 degrees, we put a minus cylinder at 150 degrees in order to weaken this 60 degrees. So 60 degrees is the steep meridian. So we want to now remove the stitches because, as we mentioned, the stitches will cause steepening. So if we remove the stitches, this will cause flattening. What is the most single suture that will eliminate the effect or decrease, let's will not say eliminate, it will say decrease the effect of a steepening at 160, it will be that of at 2 o'clock. So, but this is not unlikely to, or it is unlikely to remove the effect altogether, but it will just eliminate, have the highest reduction to eliminate the astigmatism. So to just summarize, in order to decrease the astigmatism, you need to work on the either the steep meridian or work on the flat meridian. If you want to work on a steep meridian, then you have to decrease it. How to decrease it? By removing the suture or by making an incision over it. And how to decrease the astigmatism by working on the flat meridian, it is just by doing compression sutures over it. So this rule can be applicable for even for your practical life in surgery, not only for the basic exam. I guess that we answered this question before, so we will skip this. Okay, let me explain this question for you. And I will also let you know what are some of my objections to this question. A 7-year-old child was incidentally found to have a slight exophoria with a +5 diopter in either eye with cycloplegic refraction. So here it is asking what is the best course of action. To prescribe +3 diopter to wear for close work as needed, or to prescribe the full correction for constant wear near and distance, prescribe full correction to wear for reading only, or see him in 1 year and repeat your refraction. So what happens to this child? This is a child who has a +5 diopter of cycloplegic refraction, has decreased, has hypermetropia. And this hypermetropia resulted in that the patient is trying to struggle to see the near target and near and distant target with no use. So he is trying to use his accommodation all again and all over again, and this is result in that his accommodation is fatigued, his accommodation is exhausted. So what is the result of this exhausted accommodation? That the patient lost his interest into the near targets, and this result in some weakening of the medial recti, causing them not working, leading to his eyes are deviating outward, causing exophoria. This syndrome or this condition is called a frustrated accommodation. a frustrated accommodation or hypoaccommodation, in which the patient has accommodation, has hypermetropia, resulting in that he is trying again and again to do accommodation, but with no value. So his accommodation his accommodation is fatigued, resulting in that he is not using his accommodation anymore. That will result in exodeviation of the eyes. So regarding this condition, what is the best course of action? Actually, the question is missing a lot of data. First of all, it is missing what is the pre-cycloplegic refraction, because we don't know how much the patient accommodates, since we don't have his pre-cycloplegic refraction. This is a problem. We don't have his visual acuity, and we don't know if he has amblyopia or not. And also another problem with the question, that hypoaccommodation, classically speaking, doesn't occur with +5 diopter. This is too little to cause hypoaccommodation. This occurs with high hypermetropia like +8 or +10. But for a 7-year-old child who has +5 diopter of cycloplegic refraction, so we just remove 1 diopter of ciliary tone, so it will be +4. +4 diopter is not that much that the patient cannot overcome. This is not very true regarding this question. But anyway, we will deal with the question as it is. So what will be the best suitable answer regarding this scenario is to prescribe +3 diopter to wear for close work as needed. There is nothing in this context called as needed. It is either needed or not needed. But so we either want to stimulate the patient accommodation or to relax it, but there is nothing called as needed. See him in 1 year, again, this is not a true answer, because there is no room for this very distant follow-up. We can watch him for after 2 weeks or after 1 month after initial correction, and then we can follow up like every 3 months or every 6 months. But 1 year in a patient who you didn't prescribe him any correction, this will result in amblyopia, especially that he has +5 diopter of hypermetropia. This, if you see him after 1 year without correction, this causes him amblyopia. So here we have two confusing answer. Prescribe the full correction for constant wear and near and distance, or prescribe a full correction for working or for near or for reading only. The true answer is to prescribe the full correction for constant wear, near and distance, because here prescribing full correction for reading only will not correct the hypermetropia for far that the patient has, and again will makes him unable to accommodate and will cause him more amblyopia. We don't have an option for partial correction here, Dr. Sidharth. Okay, let's move to the next question regarding the SRKT formula. No, it is not. The axial length is multiplied by 1.25. So we said before in the biometry or the intraocular length formulas lecture that the SRKT is referred to tall. So the difference between the SRKT and the SRK, the normal SRK, that is taken into consideration the intraocular lens position. So here the A constant is dependent on the final intraocular lens. This will be the correct answer. And the other answers, I don't even have the accurate numbers or figures, but the first one is a true answer. And you don't know if for the case of the MCQ, you don't need to know every answer because this is not what the MCQ are meant for. Yes, the IO, the IOL material, the A constant is dependent on the IOL material. This is one thing. Just let me check. Okay, let me check this question. I think that this is something wrong. Let me check this question and I will tell you. Okay. Okay, I will skip it now and I will check it again and tell you in the chat box in the WhatsApp. Okay, let's move to the next question. So let me explain this question because there are some topics that are discussed in the instruments. So you can see that there are some questions in the exam that can combine different topics. Here, this question is asking about the low vision aids and the telescopes. So regarding the low vision aids, the Dove prism is incorporated in a distance Galilean telescope to render the image erect. Actually, one of the advantages of Galilean telescope that it will render the image erect. So no need to incorporate a Dove prism to erect the image. And this will, the Galilean telescope will be discussed in the instruments. A high spectacle reading addition more than +3 may be used as a low vision aid. You may remember that. Okay, we said that we don't give presbyopia correction more than +3 to avoid athenopia. But here it is asking about a low vision aid. Can we give a +3 diopter, more than 3 diopter, as a low vision aid? The answer is yes. We mentioned before that we can incorporate high plus lens like +10 or +20 in our glasses in order to magnify the image so that it can act as a low vision aid. And this actually has a rule that will control this aid or the low vision aid or plus lenses as low vision aid. This is called the custom boom rule. What is the custom boom rule? This is mean that the near aid or the low vision aid that we are giving or are adding to the spectacle is equal the reverse of the Snellen notation. How is that? Let's say, for example, that the patient vision is 660 using the Snellen acuity chart. Then this patient, if this patient, of course, has poor vision, let's say, for example, that this patient has age-related macular degeneration and he has poor vision and his vision now is 660. If we wanted to make him a simple method for low vision aid, we can add to his prescription the reverse of the 60 of this Snellen notation. So it will be 60 over 6. So we can give him 10 diopter. So putting a high plus lens in front of his eyes like this will cause magnification of the image and will add him or will assist him in order to see the near targets more clearly. So this is can be used as a low vision aid. The magnifying power of a convex lens of low vision aid is one half of the dioptric power of the lens. We said before that this is not true because the magnification is equal the power divided by 4. This is the rule of magnification. We said before, if we have a handheld lens or a loop that has a power of like about 32 diopters, then what will be its magnification? It will be 8 times. So it will be 32 divided by 4. Finally, the objective lens of the Galilean telescope must be a higher power than the eyepiece. Actually, this is not true. We will mention in the instruments lecture that the eyepiece power is at a higher but at a minus power. So here, always the eyepiece is stronger than the objective lens, and it is minus. Here in the question, it is saying that the objective lens is higher, but this is not true. Another question about the use of simple magnifying group as a low vision aid. Yes, that's correct. Although again, I have some objection regarding this question. So regarding a simple magnifying group, which one of the following statements is most likely to be true? A strong negative lens is used as an objective. This is not true. We use a plus lens. And it is only in the simple loop, there is no objective and eyepiece. It is only a single lens. An erect image is produced when the object lies beyond the anterior focal point. Again, this is not true. An erect image is produced when the object lies within the anterior focal point, not beyond. If we place the object beyond, then this will result in an inverted image. Magnification is produced in all meridians because this is a lens, not or the loop is a convex lens. It is not a cylindrical lens, or it's a spherical lens, not a cylindrical lens. Maximum magnification is defined as f divided by 4, where f is the power of the lens in diopter. This is true, but actually, to be frankly speaking, this is not the maximum magnification, because the maximum magnification occurs when we are placing the object inside the focal length, not at the focal length. Because if we are placing the object inside the focal length, then the maximum magnification will be m equal f divided by 4 plus 1. And we said this before in the magnification lecture and also in the low vision aid lecture. So in order to get the maximum magnification, we just need to place the object inside the F. But this is the most correct answer regarding this scenario. So we said before that here is the object. If the object is placed beyond the focal point, the anterior focal point, like this, if we are placing more forward like this, then it will produce an inverted image here and like this. And if the object is placed in front of, or if the object is placed at the focal length of the lens, then the magnification will be equal f divided by 4. But if it is inside the focal length, then it will be f divided by 4 plus 1. Okay, let me ask you a question. When we are doing an argon laser photocoagulation in the periphery of the retina for cases, for example, of diabetic retinopathy, what is the pigment that will absorb this argon laser? So we agree that the argon laser will be absorbed by a pigment, thus it will induce its thermal effect. Yes, exactly, because there is no xanthophyll there. So argon laser is, yes, it is B. So argon laser is well absorbed by the xanthophyll. It is actually what is the well absorbed by the xanthophyll at the macula is the blue laser, not the green laser. It is the blue laser because the xanthophyll pigments tend to have higher sensitivity to the blue light, and they absorb the blue light better at the macula. And you may wonder, but we don't use this blue light at the macula. And I will tell you that's correct because the green is safer. The green is not well absorbed, but it is more safe at the macula because it is not well absorbed as we don't want to destroy the macula by the laser. So we use the green laser as it is safer, but the blue light will absorb the light, or the xanthophyll pigments will absorb with the blue light more strongly. The continuous wave argon green laser is mostly absorbed by the melanin pigment. That's why we are using it in the argon laser photocoagulation, for example. It will produce its thermal effect through its absorption by the melanin pigment. Excimer laser can cause a rise in temperature in the areas of being treated, but doesn't cause collateral damage at the area surrounding the area being treated. And the YAG laser is not absorbed by the lens capsule. This is not correct. Yes, I guess that this is an easy question. Toric contact lens can be used for correction of astigmatism. That's right. Yes, exactly. So regarding the refractive laser surgery or the LASIK, which is one of the following statements is most likely to be true. LASIK cannot be used to correct amblyopia. This is like a basic information. The amblyopia is on the cortical level, not on the eye level. So correction of the refractive error after amblyopia occurs, this will not help the amblyopia. The central cornea is steepened in the correct myopia. Actually, this is not true. Let's say for the cornea is flat in the periphery and more steep in the center. If the patient has myopia, we are just hitting the laser in the center. So this will result in flattening of the center of the cornea. So the cornea will be like this. This flattening of the center will help to correct the myopia. The central cornea is thinned to correct the hypermetropia. Again, this is not true. In the hypermetropia treatment, we hit the laser in the periphery. So by hitting the laser in the periphery, we are making the periphery more flat, resulting in more steepening of the center, which will cause increasing the refractive power of the cornea and correcting the hypermetropia. The corneal surface is made more spherical to correct the astigmatism. This is correct. So the astigmatic eye or the astigmatic cornea is not spherical, but we are trying to ablate the steep meridian in case of astigmatic cornea in order to try to render it more like the emmetropic eye or emmetropic cornea, making it more spherical rather than oblique. Please remind me in the chat box. I will send you the link of my refraction lecture of the clinical exams. So I thought I now believe that it will be helpful for you because a lot of questions are asking about the practical steps of refraction, and this I discuss in the clinical courses. So I will send you the link for this lecture. During the subjective refraction, which one of the following statements is most likely to be true? It is important to allow the patient time to accommodate through a negative lens. Actually, this is not true. Actually, after we do the subjective refraction, or sorry, the objective refraction by the retinoscopy, the next step is to do the spherical adjustment. How to adjust the sphere of the patient? This is by use of the plus and minus 0.25 spherical lenses. We offer the patient the spherical lenses in a specific manner that I will discuss I discussed in the lecture that I will send you. But anyway, in the negative lens, we offer the patient a negative lens, but we just place it in front of his eyes for few seconds. If the patient reports that there is no preference, or if the patient immediately reports that he can see better with it, then we leave it. But if the patient takes some time in order to say, okay, I see better with it, or there is no difference, we remove it immediately. We don't allow the patient time using a negative lens. Otherwise, the patient can accommodate and overcome this minus lens. So the refraction will be over minus. And if the patient has over minus refraction, this will result in over accommodation and ocular strain and athenopia due to accommodation. So to summarize, when we are offering the patient a negative lens, we should place it in front of his eyes for only a few seconds. If he says immediately that he sees better with it, then we will leave. But if he says with some time that he sees better with it or there is no difference, then we will remove. It is common for a astigmatic patient to subjectively accept more power. This is not true at all. Usually, the patient doesn't more power in the cylinder than it is found on retinoscopy. Actually, this is not true because in the retinoscopy the patient can sometimes use or accept more power in the sphere. Because during retinoscopy we are eliminating the action of or eliminating the effect of accommodation. So it is not uncommon for patients during subjective refraction to accept more power in the sphere. That's why we are adjusting or we do this verification in the end. But for the cylinder, it is not common, as these patients usually the cylindrical power will be the same in the retinoscopy and after retinoscopy. And also, the patient is usually reluctant to accept more cylinder, as the cylinder, as I told you, especially if the patient is wearing the cylinder for the first time. Usually it is wise to undercorrect him because it is not common that this patient will accept a high cylinder. This is because he is not usually accustomed to it. Maddox rod is not a test for stereopsis. It is a test for heterophoria, and this heterophoria for FAR. So as we mentioned in the PRISM lecture, the Maddox rod is used to detect if the patient has hyperphoria, hypophoria, esophoria, exophoria, and this is done for far. But if we want to measure the heterophoria for near, then can be done by the Maddox wing. When assessing the cylindrical axis with a Jacksonian cross cylinder, the patient should fixate on a circular letter on the visual acuity chart. This is true because we want the patient to detect if the letters are more circular or more round, or there is any irregularity in the contour. And this can be done by a letter T, for example, or a letter E. This can be done by a circular letter like letter O or letter C. This is how the patient can detect if the contour of the letter is irregular, which occurs when there is astigmatism. Another question about the visual acuity chart. So let me explain it until we discuss the visual acuity in the physiology. The logMAR visual acuity chart is most likely, it uses all the letters of alphabet. This is not true. It uses a specific letter in the alphabet because we want this letter to subtend a specific angle and have a specific configuration. Result can be compared at a tested distance of 3 and 6 meter. This is true. We can even adjust the letter size to be proportionate to each other. So the test can be done at 6 meters or at 3 meters. Sometimes we can do a 3 meters with a mirror behind the patient. So these 3 mirrors or 3 meters can be replicated to be 6 meters. So both of them can be true. There are no small letters than the larger one. The numbers of letters or the sizes of the letter are proportionate to each other or proportionate to the lines that they are situated in, and the distance between the letters are also proportionate to the spacing between the letters are proportionate to the line that they are presented in. They are more suitable for research than the Snellen. So the Snellen acuity, it is like 6 or 6 over 18 or 6 over 12. This cannot be used for research, but when we are using the logMAR visual acuity chart, mentioning that the patient has 0.1 or 0.2, it is easy to calculate 0.2 to 0.1, but it is not easy to calculate or to add 6 over 6 with 6 over 18. This is the same. This is the logMAR chart. You can see that there is a regular spacing between the letters, either in the vertical direction or in the horizontal direction. You can use specific letters in the alphabet, and there are the smaller letters you can see, there are very few actually, but the larger letters are more, and even this sizes can be different from one chart to the other, and this can be adjusted according to the distance. These size of the letters can be adjusted according to the distance between the patient and the chart. Yes, your answers is correct. Regarding the Jacksonian cross cylinder, it is made of a spherocylindrical lens in which the power of the cylinder is twice the power of the sphere, or the power of the sphere is half of the power of the cylinder. It is used to check the power of the cylinder before the axis. This is not correct. We said that A comes before P. So axis is first, then power is second. It is not useful when refracting the children because it needs cooperation, and usually children are not cooperative. A one diopter Jacksonian cross cylinder is an equivalent of minus 5 diopter of a sphere and plus 1 diopter of cylinder axis 90. This is correct because this is a spherocylindrical lens which has a spherical equivalent of 0, and it has the cylinder twice the sphere with reverse sign, and the cylindrical power, or the power of the cross cylinder, is named after the cylindrical power. So this is the true answer. Yes, is regarding the near correction, which is the following is most likely true. Continue the testing until the patient read N5. So any series are the name of the visual acuity chart, and every letter is named after an N figure. And we continue the test until the patient reads the smallest letter he can see, not the N5, not necessarily N5. We don't give the strongest lens. We just explain this, or we already explained this. And we start by correction of the distant, by correction of the sphere and cylinder, and starting by full distance correction. This is true. So here is the in series chart. Apologies for the bad quality of the image, but this is an example showing different sentences with different sizes, and this is referred to N. So N meaning that this is the N near chart, and we continue the near chart or continue testing until the patient sees the smallest line. I guess that we answered this, the prismatic jump. So regarding the prismatic jump, we what will we decrease the prismatic jump? We not increasing the reading segment will increase the prismatic jump. Put a prism base down prism will increase the prismatic jump, but we put a prism base up. Base in is not a solution, and raise the height of the optical center of the reading segment as we mentioned before. This is a rather tough question. I will, we again, this is depending on the topic of binocular vision, which will be explained in the physiology lecture, but this question appeared in the optics, so I prefer to answer it here. Okay, let me explain it. Regarding the HIS screen or Lee screen, this is a test used to detect of the abnormal or detection of the extraocular muscle motility problems. This test is a dissociative eye test, meaning that it dissociates the right eye and the left eye. It depends in that every eye will see a different image. So it depends on that both eyes are working together. Let's now read the answers. Patient must have normal retinal correspondence in order to perform this test. The retinal or normal and abnormal retinal correspondence will be explained in details in the binocular vision. But for this question, the normal retinal correspondence is not a prerequisite for the HIS test screen. Again, the normal retinal correspondence is not a prerequisite for the HIS test. If the patient has normal retinal correspondence, he will get normal result. But if he has abnormal retinal correspondence, his eyes will be deviated and he will have abnormal result. So this is not a must or not a prerequisite for the HIS test. Patient must have simultaneous perception in order to perform this test. This is true. The simultaneous perception is a prerequisite for the test, meaning that, again, as I told you, this test depends on dissociation between both eyes. So if the eyes cannot see at the same times, like, for example, if one eye has suppression, then the test will be of no value because, again, it dissociates both eyes. The test is useful for a measurement of eye movement in extremes of gaze. It's not extremes of gaze. Actually, it can be useful for any gaze, or it is if there is any abnormal gaze of the eye, it will be helpful for them. So finally, the test provides useful information when examining and following up of the children and the competent strabismus. Actually, no, it is useful for examination of patients with incompetent squint, not the competent squint. And it is not useful for, not very useful in children because it needs the cooperation from the children or from the patient, and children are usually not cooperative, as we mentioned in the cross cylinder. Again, a question about the Ishihara test plates, which is explained in the color vision of the physiology. So these actually are not optics question. I don't know why they are presenting it in the optics. Exactly, this test can be a good test for subtle optic nerve pathology. So why other options are wrong? Ishihara test is a booklet that is used to detect can be used for commonest form of color blindness. The first plate, which is the orange or blue, it is not the most sensitive color discrimination test, but actually it is used for screening only. This can be used for screening and for malingering. So if the patient reports that he cannot see the first plate, this means that he is malinger, because even if he has color blindness, he will be able to see it, as it is used for screening. The test plates are most sensitive for macular dysfunction. This is not true. For macular dysfunctions, usually these patients will complain of blue and yellow color defects. And these blue and yellow color defects are not tested by the Ishihara plates, with some few exceptions, but this is not the common case for macular dysfunction. Test plates are complete set, assess the most elements of color, color discrimination. Again, this is not true, because although this can appear like a true answer, but the Ishihara test is a test for color perception, not color discrimination, meaning that the patient can either see or don't see the color. But in order to the patient, we can't tell if the patient can discriminate between different grades of color using this Ishihara test plate. Again, it can be used for either detection if the patient can see or cannot see. But there are other more useful tests for color discrimination. This test can be used for subtle ocular nerve pathology. This is the correct answer. Actually, the term subtle optic nerve pathology is a broad term, like describing optic nerve disease in general. And although there are some exceptions like glaucoma, or this can be caused blue-yellow color defect, but this is not the rule. The rule is that most cases of optic nerve pathologies, like optic neuritis, like ischemic optic neuropathy, can cause defect in the red-green color. And this test is useful for the red-green color, and even it can show impairment of the test even in the earliest cases of optic nerve diseases, and usually affected by or affected before even the visual acuity is impaired. So here is the Ishihara color blindness test. This is the first plate is used for detection of screening or malingering. And this test can be used for detection of the protanopia and deuteranopia, which is the red-green defect and red defect and the green defect. On the other hand, it cannot be used for tritanopia, which is the blue color defect. So even if the patient has tritanopia, he can see the letters inside the Ishihara plates. Okay, let's come to the final question. Can you have a second thought? Yes, who said that the fourth answer will be correct? So it produced magnification equal to the focal length, and length is in millimeters, so it is not in millimeter. The focal length is in meters. So D is not correct. Can you think of another answer? So it produced an image that is real. Do you think that the image is real? What is the image produced by the magnifying lens? It is virtual, yes. So is it, does it produce the highest magnification if the object is close to the lens as possible? So if you have here a lens, and this is the F or the focal length, and this is the C or the center of curvature. So if we are placing the image like here, or the object like here, or here, or here, what is the highest magnification or the maximum magnification of option or object 1 or 2 or 3? Can you tell me? Remember the rule, magnification equal f divided by 4, and magnification if the object is at f or the focal length, and the magnification equal f divided by 4 plus 1 if the image if the object is placed inside f. So if the object is placed inside f, then the magnification will be equal f divided by 4. If the object is placed inside f, the magnification equals f divided by 4 plus 1. So what will be the highest magnification? By the way, this f is the power, but this f is the focus. Don't confuse. Exactly. So within the focus, we can reach the highest magnification because within the focus, the object is placed as close to the lens as possible. So as we move, here is like this, if we said before that this lens is 32 diopters and we place the object at f, so the magnification will be equal 8 times. But if we move the object inside f as close to the lens as possible, then the magnification will be 8x plus 1, so it will be 9x, which will be the highest magnification possible. I think that this is clear now. It is used to view the object situated within the focal point of the lens, like 3. So does this mean that it cannot view the object number 1? So here is the trick. Doesn't say magnify, but it is saying view. When it is used in the question 1 or in the option 1, it is asking about magnification. But in the option 2, it is only asking about viewing. So we can view the object, whether it is number 3 or number 2 or number 1, but with different magnifications. But it cannot magnify. It will magnify the object if it is present at the focus or within the focal length inside the F. So it can view the object at present at any plane, not only within the focal point of the lens. Is it clear? Okay, thank you very much. This is the end of our lecture today. I hope that you enjoyed the lecture, and these topics, which looks like a little bit difficult, are more B. I told you the answer will be A. So all this explanation and you still don't know what is the answer? So I hope that you enjoyed the lecture and it is becoming more easy and handy for you. And again, I apologize for the delay that happened today. Does anyone have any question regarding today's lecture? Yes, the link I will send you in the WhatsApp group. Any question? Okay, thank you very much and good night.